Awesome. Hi, my name is Madison,
Hi, I'm Michaela.
and this is our project on Norway and COVID-19. So for the epidemiology, Norway has had a total of 12,050 positive cases of COVID-19, which is one of the lower countries that have had positive cases. They've had 265 deaths that have been confirmed from COVID-19. 10,371 patients have recovered from the virus, and they do have a lot of tests. They are constantly testing their citizens, so there have been 860,115 tests that have been conducted. This was updated as of September 10th, 2020. February 26, 2020 was the first positive case from a resident living in Tromsø after coming back from a trip from China. So the person was followed, they tracked him. Apparently he was in China with where there were other cases, and he started having symptoms, and they ended up tracking him, and he was the first positive case that Norway had. Most of the cases were from Norway, from Oslo, which is Norway's capital city, one of the biggest cities in Norway. They hold the highest amount of positive cases with 3,769. Viking County has the second highest with 3,493 cases. Vestland has 1,442 cases. Trøndelag has 642. Inlandet has 604. So these are more of the bigger counties of Norway. The least positive cases in Norway are in the smaller cities. Nordland has 191 cases. Møre og Romsdal has 191, and Troms Offenmark with 331 cases.
So we see next the testing and mortality rate. Norway's mortality rate is far less than most countries at approximately 0.45%. According to Norwegian Institute of Public Health, Norway tests more of their population than the surrounding European countries. They're very similar to how South Korea has tested and treated their countries. A professor at the University of Oslo believes that Norway has less antibiotic resistance than other European countries, so it will be easier to treat Norwegian patients. And if you look on the slide, there's a graph of the case fatality rate of the ongoing COVID-19 pandemic.
Yeah, because see, Norway's literally, I think, the second lowest country out of everyone. So this is a weekly report that's direct from the Norwegian Institute of Public Health. I found this report online and wanted to include it in the slides. Basically, this was taken of week 37 week 37 of tracking COVID-19 in Norway. They found that the median age since the first case is actually 40 years old for most of the patients. In week 37, and week 37, it was 29 years. Week 37, the highest number of reported cases in relation to the population was observed in the age groups between 20 to 39 years old, 26 per 1,000, and 13 to 19 years, 18 per 100,000. During the last week, the proportion of positive results was below 1.3% in all of the age groups. But I found this was very interesting that their high, the people who were most affected were either around 40 years old or teenagers. It's also said that several genetic subgroups of the SARS-CoV-2 virus have been detected in Norway. The largest proportion belongs to the genetic group B1, which was most widespread in Europe. So they've been seeing several genetic subgroups of the virus in Norway. I haven't seen this in the United States, and was interested that they were able to test and figure out, since they have so many tests available, that they found out that there was a genetic subgroup of the virus. In questionnaires conducted on random samples of population, respiratory tract symptoms were reported in the month of August-September in about 9% of both children and adults. In the last period up to 11th of September, we see a sharp increase in respiratory symptoms that are now reported by 23% of children and 17% of adults. I know originally there was kind of people in the United States were saying children couldn't carry the virus and give it to adults. So I was really interested to see that they found a 23% case of children having respiratory symptoms. A total of 1,288 patients were confirmed with COVID-19 had to be admitted to a hospital in Norway. For 1,066 patients, which is 83%, Soros RHF, and 4 to Helsevest RHF, highest number of the new admissions in the week since week 17. In week 36, which is the week before this came out, there were 9 patients admitted to COVID-19 as the main cause, 12 in week 35 and 12 in week 34. One new patient with confirmed COVID-19 was admitted to an intensive care unit in week 37. In week 26, there's been no more than one new patient admitted to an intensive care unit per week. In week 36, again, the week before this study came out, antibodies to SARS-CoV-2 were detected in 2.3% of randomly tested participants in Norwegian cohort studies. The proportion who tested positive can vary from week to week as an expression of random variation in the sample who are tested. Since week 18, almost 7,000 people have been tested and antibodies have been detected in 1.2% of these.
So now we're moving on to the medical care and public health infrastructure. First, we see the pricing and how it's set up. Everyone is entitled to medical services. Hospital admissions are free of charge, and once you pay a certain amount, you will receive an exemption card. For the higher risk groups, according to the Norwegian healthcare website, those with underlying conditions are at a higher risk. Men are at a higher risk than women, and elderly patients are also at higher risk.
For the Norwegian health insurance costs, Norway has universal health care, meaning the health care is provided by taxes and payroll contributions. People are automatically enrolled in health care, and only 10% of the country has private insurance, which is very different from the United States. Primary, ambulatory, mental health, and hospice care, as well as select outpatient prescription drugs, are included in the insurance. Some services require co-pays, which do have out-of-pocket caps. The municipal and national general tax revenue and contributions to national insurance by employers and employees. It's a quote of what feeds into the Norwegian healthcare costs from the Commonwealth Fund. Health insurance is provided to all, no matter what social or economical factor or location of the citizen.
Here we have the Norwegian health system diagram. This is from the Commonwealth. And we see the organization of the health system in Norway, how it's set up with Parliament, the national government, the Ministry of Health and Care Services, and then underneath we see the municipalities, the countries. Under Ministry of Health, we see regional health authorities, hospital trusts, hospitals, countries. We see dental care and public health. Under the municipalities are over primary health care, care services, and rehabilitation, as well as social services. And then as well, the Ministry of Health and Care Services has Board of Health Supervision, Director for Health, Director for eHealth, Medicines Agency, Institute of Public Health, System of Patient Injury Compensation, Complaint Body for Health Services, Biotechnology Advisory Board, Food Safety Authority, Radiation Protection Agency, and the Norwegian Health Network.
So this slide goes over diseases that are leading to a higher risk in Norway. This is also from the Norwegian Institute of Public Health. Age is a key factor leading to higher risk in patients being hospitalized. The number of hospitalizations and death per 1,000 rise with increasing age. Mortality increases significantly from age 70 and onwards. the median age of those who have died was 84 years, according to the weekly report of June 3rd, 2020. This is a direct quote from the Norwegian Institute of Public Health. Cardiovascular diseases increase risk of COVID-19. Obesity, people who are morbidly obese have had a higher death rate. Chronic lung disease, so COPD, chronic obstructive pulmonary disease, increase the risk for severe cases of COVID-19 more so than asthma does. People who are immunodeficient and have HIV infection with low CD4 counts increases the possibility of severe cases and death. Patients who have been treated for a hematologic cancer within the past 5 years are at a higher risk of death. Patients who have received an organ transplant are also a higher risk, and patients in nursing homes are considered a high risk due to increased age, limited mobility since they're not really walking around a lot, and possible underlying health conditions.
Now we're going to continue with the public health. It is recommended that people with respiratory symptoms who have been traveling to higher risk countries or been in contact with those exposed to the virus or those who suspect they've had COVID, they should be tested as well. Testing for COVID in Norway is widely available and thought to be why Norway has been less affected than other countries that are surrounding them.
Excuse me. Contact tracing in Norway is very different than what we've seen in the United States. Norway consistently follows up with those that have been infected to ensure that others do not become infected with the virus. They require quarantining as part of their contact tracing. District medical officers and healthcare institutions conduct the contact tracing in collaboration with the Norwegian Institute of Public Health. So they trace low-risk contacts and those that have been exposed during air travel to make sure that they've quarantined and have not spread it to other people, so they can cut down on who's been exposed and who could possibly have the virus. Norway believes contact tracing is extremely important to prevent further outbreak, so that the healthcare providers have more time to prepare for a larger outbreak. Norway has chosen to limit traveling. They believe that traveling plays a very large role in transmission. They require those who have traveled to areas with higher transmission to quarantine. So if they've come from other European countries and have come back to Norway, or they're coming to visit Norway, they need to quarantine before they can go throughout the country. In events where the virus is more widespread, Norway prioritizes their testing supplies to ensure proper treatment.
Would you like to explain this one?
Yes, so this is the different phases for COVID-19 for their epidemic. They have several scenarios that have been written out so that they can prepare for like the worst case scenario. And it's thought to have been through 5 different phases. So phase 1 has the like imported cases and little transmission. So, in phase 1, they're still just practicing good hygiene and cleaning, early detection and isolation. They're still doing contact tracing and limiting travel from some areas. Phase 2 is clusters, a little different than just sporadic cases. They have new cases and they're still practicing good hygiene and cleaning, early detection. As each phase goes, more and more cases have, this is their scenario for more and more cases. Phase 3 is the main wave, so the big main wave. They're still practicing good hygiene and starting to do social distancing. This is for a widespread transmission in society. Phase 4 is when it becomes a full epidemic. Pressure on the healthcare services, still good hand washing and really pushing for social distancing. Phase 5 is the late epidemic, which is declining number of cases. So this is kind of how they have it set up. Planning, since Norway right now is very well controlled, they're kind of in, I think, phase 1 and 2 right now, but this is in case it got way bigger.
So now we are going to look at the PPE and hospital cases. Originally, Norway opted out to be a part of EU's EEA agreement, as initially Norway was very low on PPE supplies. After Norway had their first case, EU Ambassador Rolf Einar Fife signed on March 20th that Norway would be part of the joint procurement agreement. The JPA agreement ensures that Norway will now be able to have PPE supplies, but still allows them to run as an independent country. Norway was 3 days too late for two major EU purchases that included masks and ventilators, which is why they joined the JPA agreement. The EEA agreement would have allowed Norway to join other European countries to purchase a large amount of masks and ventilators at a large discount, since so many different countries were placing such a large order of PPE. Norway has done a wonderful job of assessing and controlling outbreaks by thoroughly tracking cases of COVID-19, so they haven't had the issue of overrun hospitals like the USA has had. Norway also has several strategies that they can use through 2021 in case the virus were to get worse. A quote from government.no says 6 types of measures have been applied in dealing with the COVID-19 pandemic. Number 1, hygiene measures such as frequent hand washing and cleaning. Number 2, early detection and isolation of infected persons. 3, tracking and quarantine of close contacts of infectious persons. 4, fewer travelers from areas with epidemic spread, travel advisories or prohibitions and entry quarantines. 5, reduced frequency of contact in the population, including through advice and social distancing and stricter measures such as closing down businesses, events, etc. And 6, comprehensive protective measures for residents of 24-hour nursing and care facilities, patients in hospitals, and other in the high-risk group. Measures may overlap in some extent.
I'm going to move this back over. All right, so for health disparities highlighted by COVID-19 in Norway, larger cities such as Oslo, Bergen, Fredrikstad, Sarpsborg, they were more heavily affected than the smaller counties and countries within Norway. The municipality and districts thoroughly tracked these cases, and they've been efficient on preventing larger outbreaks. So they tracked the cases that were in Oslo, Bergen, those listed. Only about 1.5% of the population has been infected with COVID-19, which is pretty amazing that they've had such a low rate. Due to Norway handling the pandemic very well, there hasn't been a huge effect on other health issues, health-wise. Norway has chosen to wait and reopen schools. I should add on that they've chosen to reopen schools for an older age range, which will be shown in a future slide.
Norway's economy with COVID-19 was negatively affected by the coronavirus. On April 24th, Norway dropped 1.9%, which has been said to be the biggest drop since their 2008 financial crisis. Norway's mainland economy dropped by 6.4% in March 2020. Norway chose to close public and private institutions in hopes to slow the coronavirus, which has negatively impacted their economy. It's predicted that Norway's domestic and foreign food demands will drop by 5.5%. As well, Norway had a huge decline in their oil pricing. However, they should be able to recover more easily than other European countries due to their $1 trillion sovereign wealth fund. This is extremely unique in Norway.
Following on to Norway's economy continued and education information. Due to the Prime Minister having strict closure rules, there has been an extremely high unemployment rate in Norway. Restaurants and bars were closed. The schools were closed from March 11th, 2020 to April 20th, 2020. That was for all the schools, and they've only really reopened for younger students, like 4th grade and under. The unemployment rate was as low as the record low since World War II. Apprenticeships were not forced to stop if training can continue safely. For education, all schools were switched to an online program. Certain schools in Norway have had an easier switch going online than others. The schools do get to choose which online program they want to use. Norway did choose to reopen their schools, but only for younger students, and that was what they reopened on April 20th, 2020. They didn't see a significant increase in COVID-19 cases.
The precautions Norway has taken for education would be schools reopened for kindergartners, first grade, second grade, third, and fourth graders, but classes were limited to 15 students and under. As well, students were required to wash their desks daily. Some schools have chosen to divide their playgrounds, but they've seen that there was not a huge increase in COVID-19 cases since reopening the school to the younger students.
For evaluation and recommendations, what went wrong and what went right, Norway has done a wonderful job thoroughly tracking positive cases, enforcing quarantines, and consistently testing individuals. They did choose to opt out of their EEA agreement, thus leading to some panic once they had their first positive case, but they were very quick to join the JPA agreement, which allowed them to obtain necessary PPE for their healthcare employees. Norway is still one of the countries with the lowest cases and mortality rates. Unlike the USA, that has experienced extreme shortage on PPE, limited hospital beds, and their employees have been exhausted from, or our employees have been exhausted from working all day, so many hours.
Now we will continue on to their plan and the three possible scenarios Norway has. Scenario 1, their first scenario is if the infection continues to be under control, they can continue providing care to those who are at a high risk or in critical care. The goal is that intervention measures can eventually be discontinued. Understanding that there might be more waves of the virus that come and go, the goal is to continue the same good quality care to those in need. If an effective treatment plan or vaccine becomes available, this scenario's possibility should be easy to continue. Scenario 2, Norway's second scenario is if they were to hit a high wave of people where it would be hard to provide the same health services and care to all of those who need it. Reintroductions of intervention measures would possibly happen depending on the negative effects Norway receives health-wise, economy-wise, and capacity-wise. Scenario number 3 is if international cooperation has been weakened and instead of working together with other European countries, each country continues to help benefit themselves but not others. If the European emergency response is discontinued, this will affect Norway negatively. This could affect international travel from resuming, care for Norwegian citizens, and can crucially affect the market. Norway relies on their market for PPE supplies, making a restriction on trades and manufacturers who provide medical supplies to Norway.
Continued scenarios for Norway, they do acknowledge that there may be a situation where they're unable to control the infection for a long period of time. This will be more likely to happen if Norway doesn't have a vaccine or medications to help treat COVID-19. This will also cause Norway's economy to suffer, however, which leads to a negative chain of providing good health care to those who are affected by the pandemic. Norway's long-term plan is prepared for dealing with the first or second scenario. Norway states that if they were to enter that third scenario that Michaela was discussing earlier, that they would need to stop and readjust their plan. They're constantly working on being prepared for a negative outbreak.
Norway's current scenario, which is the one with higher cases, we're going to talk about that. Norway is currently at a high risk for contracting the coronavirus. The CDC has recommended that non-essential travel to Norway should be avoided. Norway is currently on a level 3 warning for avoiding all non-essential traveling. Norway's prime minister has put a stop on the gradual reopening of the country. I think that was in July 15th.
Yeah, you're correct.
They decided they were going to halt it for a little bit. They started to spike. They highly recommend face masks, but they do not require them. Norway banned serving alcohol after midnight since August 7th, which is still in effect, and packages have been delayed to the USA and Canada.
Sorry about the typo. So this is a big, long list of different response plans from Norway, because they've done a great job, but they've also created that long-term plan. These are just a list that I've taken from their response website. It's just a list of the health preparedness plan, strategy for hazardous substances, the national emergency for infectious diseases, the national influenza pandemic plan, the control of communicable diseases and act, and this includes regulations relating to the Norwegian surveillance system for communicable diseases, MSIS, and the regulations of relating to notification measures in the event of serious incidents affecting international public health. So it's the Health Preparedness Act, Norwegian Public Health Act, and regulations for control measures. So this is just a big long list that Norway has posted of what they can do.
So we've already mentioned some of the policies and regulations. Norway's shutdown was extensive at the beginning, with all schools, sports, salons, gyms, museums, pools, libraries, and restaurants being shut down. I believe that restaurants now can only be open if they can ensure a 3 to 6 foot distance between their customers. As well, anyone traveling back into the country was required to be home quarantined for 10 days, even if they were not exhibiting any symptoms of COVID-19. This is still the requirement, because as we talked about, their reopen plan was halted for now. People from countries outside the EEA, Schengen area, or the UK who have a work and residence permit in Norway, have family or a partner in Norway, or are students or workers with technical competence that is exempt from the residence permit requirements can travel into the country. They're still required to do that 10 days quarantine. As well, healthcare providers are not allowed to travel abroad whatsoever.
Continuing on to their policies and regulations, Norway does not require face masks. They only kind of require and recommend it for public transportation. This began around the middle of August when they experienced a spike in cases. This is not a mandate from the government as understood. It's a very strong recommendation.
The community and government response. Norway's first case was around February 20, I guess it's 26th or 28th, somewhere around there. And they implemented a full lockdown beginning mid-March. So I think that they were pretty quick to recognize what was happening and go into a lockdown. They've had a stricter lockdown than many other European countries surrounding them. As we said before, they began to open their borders July 15th, but quickly halted that because of the spiking cases. They do not require masks unless they're unless public transportation is being used by their citizens. So the government response was swift, and they seem to have taken care of it and kept their cases low. As well, the community response has seemed to be positive. They have seemingly complied with the restrictions put in place. As I read in several articles, they took the virus seriously, and this is evident in the fact that their cases have still been low for the most part.
For evaluation recommendations, we believe the country's level of effectiveness was very high. Norway has a population of 5.4 million, and they're estimating around 12,000 cases of the virus so far, with only 260 deaths. Overall, their response seems to have been pretty effective. Their response was implemented quickly. As Michaela had said, it was very quick. They were quick to realize what was going on. One challenge may be there was not a mask requirement like the United States has, where we're mandatory to wear it out in the public at all. They have kept their cases low, maybe a contributor to the cases that are beginning to spike now, or when they first had that spike. The USA could learn from their response to the viruses by complying to restrictions and not fighting rules that have been put out in place. We do have a larger population than Norway, but attitude has been shown among the authorities and communities, something we can model. Michaela might want to add on to, she did a lot of this part of wearing masks and stuff like that.
Yeah. Basically, I think it was the end of August when the spike happened is when they began to recommend masks. I know a lot of countries that are surrounding them they're not really even recommending. They're kind of, they have other measures put in place, but mask is not part of that. But when Norway began to spike, that's when they decided if people are close together, like in public transport, they recommend, but there's still no mandate.
Gotcha. All right, so that's the end of the presentation. We put a list together of the works cited. We tried to use websites that were .no because that was Norwegian websites themselves. And so we have Life in Norway, Science Norway, Common Health Fund, visit oslo.com, a bunch of different Norwegian websites. So there are 3 different pages, and that is all.
Thank you.
Thank you. Bye.